Okay. Thank you very much for joining today's Palliative Care ECHO session that is focused on the Canadian Atlas of Palliative Care. My name is Jeff Mote. I'll be your host today. Please feel free to introduce yourselves in the chat function below. The Canadian Palliative Care Atlas is the first of its kind in Canada, and it's been led by Pallium Canada and its partners, notably McMaster University, Ontario Tech University, and the Atlantis Group at the University of Navarra in Pamplona, Spain. We know from the experience from other countries that atlases act as very powerful change agents. They encourage improvements in countries with respect to palliative care services. They inform policy and funding decisions and highlight successes for the purposes of spread and adaptation in other jurisdictions. And to date, there's been no single reporting source or data repository or mapping of the state of palliative care in this country. And that is now changing with the introduction of the Canadian Atlas of Palliative Care. So we're very excited to be sharing the results of the first Canadian Atlas of Palliative Care, which is focused on one of our pilot regions, the Central East subregion of Ontario. But before we do so, let's honor the territory from which we are presenting from. Next slide, please. So before we get into our presentation, I'd like to take an opportunity to acknowledge the land in which I'm presenting from, which is the city of Ottawa, is the traditional unceded and unsurrendered territory of the Algonquin Anishinaabe people who have lived on this land since time immemorial. I'd like to acknowledge the historical oppression of lands, cultures, and the original peoples and what we now know as Canada. I think we all believe that the work that we do collectively in palliative care in this country can contribute to the healing and decolonizing journey that we all share together. Very grateful to have the opportunity to be present in this territory. Next slide, please. Next slide.
We're just having some technical difficulties. Just give us a moment.
Yeah.
Actually, while we're waiting, it's Jose. I just see someone posted a message about increasing the volume. So I don't know whether it's an issue at our end or at your end.
There we are. Okay, let's keep going. So today's presentation is part of the Palliative Care ECHO project, which is a national 5-year initiative that's aimed at cultivating communities of practice and supporting continuous professional development among healthcare providers across Canada who care for patients with life-limiting conditions. So this project is focused on supporting the lifelong learning journey for healthcare providers to help build local capacity to provide a palliative care approach to patients and families. The Palliative Care ECHO project is made possible thanks to a financial contribution from Health Canada, and the content and views expressed throughout today's presentation do not necessarily reflect the views of Health Canada. And if you're looking for more information about the Palliative Care ECHO project, please visit echopalliative.com to get more information. Let's go on to the next slide, please. Thank you. So I think it's really important to understand that the Palliative Care ECHO project is not a replacement for foundational training on the palliative care approach through programs such as Pallium's LEAP courses. If you haven't taken a LEAP course to acquire the knowledge, the skills, and the confidence to provide earlier, more effective, and more compassionate palliative care, I would encourage you to visit our website, pallium.ca, under the courses tab to get more information about courses like you see on the screen here, LEAP Core. LEAP Core is accredited by both the College of Family Physicians for, I believe it's 24 main pro credits for online and 28 for the in-class version. And this course is accredited by both the Royal College and the College of Family Physicians of Canada. Next slide, please. Okay, so again, I'm your host for today's webinar. My name is Jeffrey Mote. I happen to be the Chief Executive Officer of Pallium Canada, and it gives me great pleasure to be introducing a fulsome panel for today's discussion. So we're very lucky to have join us from across the pond, Dr. Jose Pereira, who is Professor of Faculty of Medicine at the University of Navarra, Spain. He's also the Professor of Division of Palliative Care and Department of Family Medicine at McMaster, and our scientific advisor here at Pallium Canada, and also our co-founder. Dr. Leonie Hertz is clinical professor at the Cummings School of Medicine at the University of Calgary. And as you see here, Section Chief, Pediatric Palliative Medicine at Alberta Health Services in the Calgary zone, and Director of the Rotary Flames House and Research Associate of our project here at the Canadian Atlas Palliative Care. And we're also joined by Chris Klinger, who's a research scientist at Pallium Canada and assistant professor at the Dr. Joshua Shad Pallium Canada Research Hub at McMaster University. Very warm welcome to our panelist. Okay, just some administrative pieces here to cover. Again, want to warmly welcome all of you to the session. Your microphones have been muted. It doesn't mean, though, that we don't want to hear from you. So please share any thoughts you have throughout the webinar. You can express yourself in the Q&R function that's at the bottom of your screen. We'll be monitoring that throughout the presentation. And when you contribute your comments and questions, you ultimately help contribute to the knowledge that we're going to be generating over the next 60 or so minutes. So thank you in advance for doing that. And just a very brief reminder that please don't disclose any personal health information during the session. And at the very end, you're going to see a link to a survey that's going to be placed in the chat function, again, at the bottom of your screen. So it's important to complete that because we collect this information, we collate it for future reference. And a link to the session will also be emailed to all of you within a week of this presentation. Next slide, please. Okay, so in terms of conflict of interest, I think as most of you know, Pallium is a national nonprofit organization. We were founded in 2000. We're based here in Ottawa. We're funded in part by Health Canada. As you know, we equip healthcare professionals, healthcare organizations, and communities with the skills, knowledge, and tools to provide earlier, more effective, more compassionate palliative care to all Canadians. As I mentioned earlier, the Palliative Care ECHO project is funded through a contribution agreement with Health Canada, which of course includes sessions such as these. We also derive funding from the sale of our lead courseware, our Pallium Pocketbook. And in terms of conflict, I am an employee, full-time employee of Pallium Canada, and I will ask each of our panelists to declare any potential conflicts to declare. So I'll ask all of you to disclose your conflicts, and if you have none, just simply say I have no potential conflicts or biases to declare. We'll start with Dr. Pereira.
Hi, I do receive stipends from Pallium Canada as scientific advisor for Pallium Canada.
Thanks, Dr. Pereira. Dr. Hertz.
Yes, I receive a stipend to be a research associate for the Pallium Canada Atlas project. Thanks.
And Chris.
Hello, everyone. I'm a research scientist with Pallium Canada.
Okay, very good. Thanks, Chris. Thank you to our panel. And without further ado, I'm going to pass the baton over to Dr. Jose Pereira, who is going to talk about the Atlas approach and give us an overview and the role of Atlases across the world. Jose, over to you.
Great. Thanks very much, Jeff. And hi, everyone. It's fantastic to be with you all. And looking at the chat room, looks like there are people right across the whole country. So I will be looking at the overall picture of the Atlas. What is the Atlas? What the role of Atlas is? And then I'll also look at the methods that are used to create Atlases and share with you some exemplars of Atlases done in other continents, actually. And then we'll hand over to Leonie to look at some of the results that we've got so far. So with that, then, so the Atlases are a way of showing the status of palliative care in a country across several domains. And the domains were established through this iterative participatory process that has been led by the University of Navarra in Spain, which is recognized as the Global Palliative Care Observatory by the World Health Organization. So it's a WHO collaboration center. And this group, as you can see in the diagram at the right, I think I don't know what color that is. Taupe, is it? Or khaki color document describes the indicators that this international process identified. In the middle there is a picture of what looks like your house with two blue pillars. That house has been developed by the World Health Organization in their most recent work and document related to organizing palliative care within a healthcare system. They've called it the house, and this house has got some important foundations, and those foundations include health policies and include empowering people and communities to be mobilized to provide palliative care as well. And there's a base there of research, scholarship in the field, and that includes also scholarship and research across the many various domains related to palliative care. There are two pillars, and the one is education and training, and education training relates to training not only palliative care specialists across different professions, but also healthcare professionals across many different care settings and profession groups, with those core competencies allowing them to provide a palliative care approach in their daily work as they care for patients with serious illnesses. The other pillar relates to the use of essential medicines and, importantly, access to essential medicines. One can imagine in some countries, for example, there's lack of opioids. And at the top is the presence of palliative care services. So these atlases are driven by these indicators, informed by the WHO Palliative Care House. And as is listed over there, it covers several domains. And these domains include policy indicators, so things such as strategic plans, formal offices for palliative care, formal government programs for palliative care. It also looks at service provision indicators, and these include the presence of palliative care units and hospices. And hospices are hospice homes, as well as community hospice programs. It also looks at palliative care teams in hospitals and in the community. And then, very importantly, the integration of palliative care in care settings such as primary care, long-term care, and various specialties. There are also education indicators, and these include indicators primarily in undergraduate education of the health professions, so medicine, nursing, social work, etc. We mentioned the access to medications indicator, and then also professional activities. And professional activities include things such as conferences, regular continuing education programs. So you've got these domains that then are indicators of the vibrancy or not of palliative care in a particular jurisdiction. So with that background, I think hopefully you now start understanding what these different atlases are looking like. Several have already been developed. The first one was one developed in about 2005, 2006 in Spain. And the European Palliative Care Association became very interested in that, and they said we should get one as well for the rest of Europe. And so in 2007 was the first European atlas, and that was followed up with an update in 2013 and another one in 2019. And the group in Navarra, where I'm at the moment working with, are getting ready to do the next update for the European atlas. There's an African atlas developed back in 2017, and the update is underway this year. A Latin American atlas was produced in 2013, again in 2020, and they're also working on an update for this year. There's one for the Middle East. Interestingly, there's one for Scotland, and the Scottish one stands out from the rest, and we want to highlight that because in a way the Canadian atlas will sort of mimic somewhat that. Most of the atlases are at a continental level, and they look at palliative care by country and then compare countries across a continent. The Scottish one stands out in that it was a more in-depth atlas of the palliative care within Scotland. And we'll show you some examples of what that looks like. And then the Asia Atlas is just beginning to get underway. So here are exemplars taken from the atlases. This is taken from the European Atlas, as you can see, and you can see that it's graphical presentations of those different domains. So, for example, on the left-hand side is a picture that depicts the presence of palliative care teams and services in home and community settings. The larger the circle, the more services there are, and you can see the scale that is depicted on that map. So you start getting a sense of the presence of these services, and part of the atlas, the beginning of the atlas, is also a depiction of its demographics. So now you're able to compare the demographics of a country with the size. So for example, in the western tip of the continent is Portugal. So that's where my family are from. So I'm always keen looking at Portugal. And you can see it's a small country by geographic size. It's a small country by population, about 10 million, 11 million, and so fewer services. But you also start getting an indication of proportionality. On the right-hand side, the top right-hand map depicts staff in the training of staff in long-term care facilities across European countries. And the darker, the more work has been done in training up the long-term care facilities. So if you look, Poland, for example, is actually doing quite well, as is the Netherlands, and then to a lesser degree, France, and to a very low degree, unfortunately, Portugal in the lower tip. And we had an experience of that as a family not so long ago, where a family member was supposed to receive palliative care in a long-term care home and never really received it. So we had to be really involved. Anyway, so you get a sense of what they look like. This is an example from the Scottish Atlas, and in this example, you'll see the map of Scotland, and what I'd like to draw your attention to how it's divided up into sub-regions, into various regions, and within each of those regions, they've looked at the presence of inpatient palliative care units, outpatient palliative care clinics, hospital support teams, home care teams, daycare centers. So these are daycare palliative care services. And they are depicted then using this graphic presentation. On the right-hand side, you've got the actual numbers of the units, outpatient clinics, etc. And also, it also highlights where there are some gaps, and it gives you a sense of proportionality of these different services within the different regions. So why the atlases? As Jeff alluded to earlier on, atlases facilitate the integration of palliative care across healthcare system and thereby helping accelerate access of palliative care for patients. So what they do is they identify and highlight successes with the idea of then spreading and scaling these up, as well as identifying gaps in order that these can be addressed. So these continent-wide atlases, the country policymakers, funders, healthcare managers are looking at these maps and say, oh, why are we short here? Or, oh, we're doing great here. Or Poland's doing great here. We should try and emulate that. What are they doing that we should be also doing? So they catalyze reflection and action by health system leaders, the policymakers, planners, and managers, and they raise awareness in special areas where focus might be required. So in the picture, I showed you the long-term care map. Well, in previous European atlases, they had not looked at what they call nursing homes. They call it nursing homes. And so in the last atlas, they really highlighted the long-term care or nursing home sector. So keep that in mind, because we're also trying to shine some light on populations that we think light should be shone on, as we suspect that there are a lot of gaps, or potentially a lot of gaps in those populations. So the maps identify as well similarities and variations across jurisdictions. Now, this aligns very well with the Health Canada framework on palliative care. Within the framework is written that the research and collection of data on palliative care and measure to facilitate equitable access to palliative care across Canada, with a closer look at underserviced populations. And so, as you're going to see, the atlas that we're developing helps us get to that point. So what are the methods we're using? Well, by and large, we're using the same methods as are being used in these continental atlases, as well as was used in the Scottish Atlas. Now, I'm not going to go through in any detail in the schema, except to say that there is this process that we follow. There are multiple steps. All these steps need to be done. And importantly, what you see are multiple sources of data and information. Now, the idea is not that it is an absolutely 100% correct and detailed representation. It's to give the gestalt, the overall sense of the status of palliative care in that particular domain. So usually the process starts with literature searchers looking for studies that look at the mapping of services across a jurisdiction. They also look at things such as reports, and they review reports of a country, reports of an association, be it the country, or in our case, will also be provincial and territorial. And then they undertake surveys of key informants. So they send out this survey that has operationalized these different domains, and within each of those domains are various indicators. In fact, there are a total of about 50 indicators divided up into these 7 or 8 domains. The informants are people who are considered leaders in that country, and they interview anything from 2 to 10 key informants per jurisdiction, and about 2 to 10 folks also complete the surveys. It depends on the country size and the population. And informants, as we said, are formal or informal palliative care leaders recognized by peers. Some of them have got formal positions, formal titles as leaders in palliative care. Others are more informal, but have a very good understanding of palliative care in their jurisdiction. This was the core research team that we started off with, and you can see that there's several folks from Pallium Canada. A lot of the work has been led from McMaster University, from the Joshua Shad Research Hub, which is a collaboration between the Division of Palliative Care at McMaster and Pallium. And I'll let you read the list of the different team members. We've also got someone from Ontario Tech University in Ontario. University of Navarra has been very much part of this, given their expertise in this area. And we also have someone from the Canadian Society of Palliative Care Physicians and from Lake Ridge Health. Now, we're using largely, as I said, the same methods as been used at international atlases, the publicly available data, which means we go look at websites, at publicly available reports, and other sources of data that's publicly available. We collate those. We pre-populate surveys where it's possible. So, for example, if we find that there is a strategic plan in a region, then we'll pre-populate that into the survey so that by the time the informants get that, hopefully all they need to say is, yes, this is correct, or not, and replace it with what's correct. We're going to be doing interviews with the key informants as well. And the domains that we are using largely align with the international atlases. So we're using methods and domains used internationally and recognized internationally. So for ours, we've got 9 domains, and this is the grid of the domains. So there are demographics, policy, and if you look at policy, it's things like designated palliative care office, palliative care policies, palliative care legislation, standards or norms of practice, monitoring systems, designated funding, palliative care billing codes, for example, advanced care planning legislation. Under services, there are things such as palliative care within the acute care domain, so palliative care units, specialist teams within hospitals, and in the community-based palliative care teams, hospices, different types of hospice services, home care, and also in long-term care is included as well in that domain. For system performance, this is not, and this is important, this is not a minimum data set. And so we are not going to be redoing work done, for example, by the Partnership Against Cancer, by CAI. We have that in the atlas so that we can point people towards those important reports and thereby spread word of those important reports further. And education, we're principally looking at the medical schools and nursing schools. We've tried to look at social work colleges and schools and some of the other professions. It's quite challenging. And so for the time being, the lowest hanging fruit are actually the medical schools and the nursing schools, where we can get the process going. Focus populations include the pediatrics, LGBTQ2S plus population, palliative care, for homeless and largely housed, prison populations, immigrants, refugees, and informal caregivers. In the community, we're also looking at community engagement, compassionate communities, for example, and then there's an opportunity for other activities that may not have been captured within these domains. We had started on, we felt at the beginning of the whole process that looking at Indigenous peoples, and to what extent is palliative care available to them was extremely important. We started the process. We reached out and met with some Indigenous programs leaders for input and advice. And then as the process was unfolding, we were directed to work on doing a separate detailed one that then comes together with this one. So Jeff will probably say a few extra words on that one.
Yeah, I mean, I think it was from the inception of the Atlas, one of our objectives has always been to engage, collect, and report data on Indigenous peoples within our pilot project communities in accordance with OCAP. But as Jose alluded to, based on feedback received early in the pilot project, to ensure proper representation and respect for Indigenous peoples, we will be undertaking a separate and distinct Atlas mapping process specifically for Indigenous peoples, for which we're currently seeking funding.
Thanks, Jeff. Okay, now what's unique to the Canadian Atlas is that in addition to looking at a country level, so a satellite view of the whole country, we're also going to be looking at a provincial and territorial level. And then we also recognize that within the provinces and the territories, there's considerable variation within their regions in terms of the status of palliative care, access to different palliative care programs. And then even within some of the large regions, given the large size of the country, there are sub-regions. And so the Atlas is looking at these different levels, providing an opportunity to look at not just the country level, as I said, and not only provincial and territorial, but also regions and then the sub-regions within those regions. And our goal is to reach out to 2 or 3 leaders at these various levels to get input from them. The other important difference of this one versus the other ones is that we're inviting frontline workforce to provide input. So once we've got the results of the surveys done and of the interviews, the semi-structured interviews, we'll then collate all that information, and then we'll invite local folks providing palliative care at the front lines to look at results and in focus groups to say to us, yep, that reflects the reality in our area, or this is misaligned with what is the reality, so that we've got a bit of a reality check at that level. This is just demonstrates the different steps as we go through from the beginning of the process, where we're doing the public available information down to the surveys and then the informant interviews, followed by the focus group of frontline palliative care providers. So across the country, we're hoping to invite people, including, for example, the Pallium Leap facilitators, most of which are palliative care doctors and nurses, social workers, working in the front lines and have a good sense of what's happening within their sub-regions or regions, or perhaps even provinces. Progress to date, work started in 2019. You can imagine a lot of it got stymied by the pandemic. We had to slow things down during the pandemic because everyone was so busy having to respond to the pandemic. And then so it stops and starts during that period, but we were able to tailor the domains and the indicators using a multidisciplinary group from across the country that provided input on that. We received REB approval from McMaster University for the pilot study, and then for the whole of Ontario, and then for British Columbia and Alberta, and have just submitted, and Christopher has been working on that to submit the REB for the whole country. We started piloting in 2 regions and their sub-regions, and what we want to show you are the results from the Central East region, because that's the one that we studied in most detail during the piloting phase. And I'll hand over to Jeff at this point.
Yeah, just a real shout out to the organizations behind the creation of the atlases that we've been working on to date. As you see on the right, there's a list of the organizations in Alberta. Both the Alberta Health Services and the Government of Alberta have been strong supporters of the Atlas for that province. in British Columbia. The Sovereign Order of St. John's of Jerusalem Knights Hospitaller has been an incredibly great partner of ours and champion for the Atlas, and they've always been visionaries with us in terms of what's possible. So a lot of their funding support, along with YP Young Foundation for the BC edition, and in Ontario through the PSI Foundation, and a big shout out as well to Esri Canada for providing the mapping support for the Central East subregion that we're going to be reviewing in just a moment. As you can see, we have a number of atlases already underway. While we're going to be focusing on the Central East subregion today, the reality is we're knee-deep in atlases for those 3 provinces, including some educational mapping that is being done with the RQS PAL in the province of Quebec. I think this is me as well. Yes. So Jose called out some of the different organizations involved in the research. The reality is the Atlas is a collaborative effort of many, many organizations. A snapshot of what you see here on the screen, whether these are partner organizations that provide us access to key data for inclusion in the Atlas. Others have been just very supportive of the need for this. To help communicate the results of our Atlas. So we're very appreciative and really want to recognize all these organizations. You can see it's a team sport, the development of an Atlas, and we couldn't have done it without these organizations. So a big shout out to everyone that you see here. Back to you, Jose.
Thanks very much. Good. So at this point, actually, we're going to hand over to Leonie, who is going to take us through some of the results. And then I think Chris will have some input as well.
Great. Thanks so much, everyone. We're very excited to share with you our results, some of our results from the Central East pilot. Give you a bit of a tour of what the mapping can look like. Again, thanks to Esri Canada for their fantastic supporting, helping us put this together. And of course, we won't have time today to look through all of the 9 domains that the Atlas is capturing, but we just want to highlight like how data can look and showcase its functionality as much as you can in a PowerPoint presentation. But we certainly encourage you to take a more detailed tour of the pilot Atlas through the Pallium website, and we'll make sure to put the link for that in the chat for all of you to have a look at your leisure. So I'll just start by highlighting from a display perspective. As Jose has described, data is reported by domain and particular indicators, and we're using an interactive story map functionality. And there's a dashboard, which I'll show you in more detail in the next slides, that provides an overview of all of the domains. You can more readily navigate depending on what you're interested in looking at. You don't have to scroll through all the pages. You can simply click on the domain that you're interested in. We're using maps, tables, and graphs to display details with different icons like you can see here. In the top map, we can reference different types of institutional settings, acute care, subacute, hospice. We use color coding to look at adequacy of services or presence or absence of services. So in this top map, you'll see it's shown green for having adequacy of the service. And again, just highlighting some of the colors and not going into details at this point. We also provide additional information on the local context to explain something that's either in progress or has been a challenge for the region, or that might be unique and needs to be showcased. And then for some indicators, comparisons are made to recognize standards. For example, the Catalonia formula is used to represent the adequacy of palliative care beds, and all of this information and definitions are captured actually in a data dictionary. So for ready access to understand what references are being used and what we mean by various terms. So I'll just showcase some of the way demographics are displayed utilizing the Central East region. So first, I'll just draw your attention to the bar along the top. So that really is what the dashboard looks like for your ease of navigation. And of course, it's interactive when you go to the web-based format. The demographics include like an overall description of the region. Here you can see the Central East region is a mixed urban, small communities and rural geography. We can look at the population as well as the population population density, which can be readily depicted graphically, as you can see. In this bottom graph, you can look at the population density in relation to the region with respect to the nearby regions and the province itself. And then we go into more detail to look at the region itself, shown here in the box of the Central East. So it's nice to kind of see where it fits into that bigger context. Within demographics, we also look at the subregion level, and their urban-rural profiles can be represented graphically as shown here on the left. So we use color coding to represent rurality versus the urban nature. Again, you can look at age demographics as well as number and causes of death. So different types of graphs are used to represent the different types of data and tables. So not focusing on the details so much today, but just to give you a sense of really the broad way that we are able to represent data and really showcase what's happening at a more granular level in these regions and subregions. So I'll walk into some of the domains. So under the policy domain, this is an example of looking at the existence of palliative care policy for the region across a number of indicators. So in the table, you can see the listing of the types of indicators that are being assessed for. It includes, is there a designated office or program responsible for palliative care? Is there an active palliative care strategic plan? Is there a law to ensure palliative care access? Is there a law related to advanced care planning? Are there standards and norms for palliative care in the subregions and regions? Are there compassionate care benefits? All of these are used to put together whether or not there's an adequacy of palliative care policy in this region, and again, to add that local context. So you can see here for the Central East region that overall there's adequate palliative care policy. There's some partial policies specific for long-term care at a provincial level rather than at a regional level, but overall it was felt to be quite adequate. From another indicator within policy, we look at whether there's formal and active strategies to integrate palliative care in various settings, so including home and community care, in the hospital setting, both inpatient and outpatient, within long-term care facilities, and within the paramedic emergency medicine services. So in the left, you'll see that in the Central East region, there's actually no regional level strategies for integration into home and community care or any of those other domains, except for the paramedic emergency services and some partial integration within individual long-term care homes. But more work, obviously, opportunity to be done here with respect to strategies. Moving on to service indicator on palliative care units. Here you can see the location of where the PCUs are within the region. You can see the number of beds indicated by a number next to the dot on the map. And then the color of the dot also represents the type of hospital facility that the units are located within. So in the Central East region, you can see that there are 6 palliative care units. 5 of the 6 are located within acute care hospitals and 1 in a complex continuing care. We also look at the adequacy of the overall beds for the region, which is depicted by the color coding of the region shown here in green. And that's based on the Catalonia formula. Again, all of that is referenced within the document for easy understanding. But what's interesting, so while overall we can see that the adequacy of the number of beds based on the Catalonia formula is adequate, it's acceptable. But when we look in more detail at the data, we can actually see that most of the palliative care units in this region are really serving those who are at the end of life and serving more of a hospice bed function rather than acute care beds, which we know serve patients across their illness trajectory and have a live discharge rate of more than 30%. So the vast majority of the palliative care beds in the Central East region are being used for end-of-life care, which might be an opportunity to look at how beds are utilized from a more cost-effective solution and providing more care in the community outside of an acute care bed when it's not necessarily needing acute care to serve that function. This gives you an idea of how, from a policy and funding perspective, you might be able to think about how to use this data to make the best use of resources and better meet the palliative care needs of the population. In this next slide, you can see we're looking at the integration of palliative care approach within hospitals specifically. You can see the type and size of the hospital depicted graphically. Again, color coding of where the location of each of the institutions represents the type of institution, and the size of the hospital can also be represented by the size of the markers here. The color coding of the overall region is to show that there's partial integration overall of palliative care approach across services. So when we look at integration of a palliative care approach into hospital settings, we know that it requires a critical mass of staff, including doctors, nurses, healthcare aides, and other professionals, to be trained on the palliative care approach, as well as a formal strategy in place to achieve this. So those are the elements that we're looking at in this indicator. And most of the hospitals in the Central East subregion have yet to adopt a palliative care approach within their services. Most staff are not formally trained in palliative care or need their skills updated, even though they regularly care for patients with life-limiting illnesses. And there is largely no formal strategy in place to integrate a palliative care approach into all hospital services across the region. So that's how we get the adequacy as being partial integration within the integration of the palliative care approach. Some additional context, of course, which I won't go through in detail, but is there to provide better understanding of the unique challenges or what might be changing at a regional level. So we'll now move on to look at access to specialist palliative care teams in the community, again under the indicator for service. Primary care providers like family doctors, family medicine clinics, and home care nurses need to have consistent 24/7 access to specialist palliative care supports to help them in their work and when needed to address more complex issues. This includes the provision of home visits. Across the Central East subregion, we saw that some areas had the benefit of 24/7 support from specialist palliative care in the community, while others have only partial access and with office hours restrictions, and unfortunately one smaller area shown in red had hardly any access at all. So you can see the color coding of the subregions within the Central East to represent the types of access to community-based specialist palliative care. Looking at the role primary palliative care is provided by family physicians and primary care clinics, we see a mixed picture across the Central East region. In the more urbanized parts of the region, interestingly shown in red, care is largely provided by palliative care physicians who often take over the care of the patients from the primary care colleagues. Most family physicians, including family health teams and other patient roster clinics, do not provide home visits and after-hours coverage to patients with palliative care needs in these regions. So the red here represents hardly any primary palliative care being provided by family doctors or primary care clinics. Rural-based family physicians and primary care clinics are more likely to provide primary level palliative care to their own patients, and the rural areas are largely mapped in green here to indicate that they're most often providing primary palliative care for their patients. And in some of the other subregions, the primary palliative care is being provided by family doctors and primary care teams with varying access. So that would be representing the yellow areas. So I think like this type of data highlights a gap and an opportunity to improve care. We know that it's essential that all family physicians and primary care teams are supported through training and resources to provide a core palliative approach to their patients and have access to specialist palliative care 24/7 when they need help. So this looks at an opportunity for ways that we may be able to improve support for family physicians and what are some of the barriers that they might be experiencing to be able to provide palliative care for their own patients. Hospice residences, can look at the location of hospice residences in the region. The number of beds in each hospice is depicted next to the marker, which shows the location. And then we can look at the adequacy of the overall number of hospice beds for a particular region. And in the Central East region, we can see that there are 7 hospice residences or homes for a total of 56 beds. And we know these are important resources for palliative care hubs in their community. just to note that it's important that the establishment of these hospices have been made possible by incredible fundraising efforts by their local communities, and in some cases with the support of the Ontario government through capital funding to help build them. But obviously, as the needs of the overall region is inadequate to meet the hospice care needs of the Central East subregion using the Catalonia formula, we know that at least 100 beds are needed versus the 56 that are currently there. Of note, one of the hospices has a room specifically available to provide support for pediatric palliative care at the Peterborough Hospice. And obviously this is noteworthy when we come to the focus populations, that we need more effort is needed to ensure access for children needing palliative care in the different regions, not just the Central East region. I won't spend any time on this. I want to make sure we leave lots of time for questions, but we also are looking at community hospice services, so not just hospice residences, where they're located and what the type of services they're providing. Long-term care, looking at the integration of a palliative approach and education supports within long-term care. Again, you can see in the mapping that the number of long-term care homes in each of the subregions and the overall integration of a palliative approach we're showing as partial, just to highlight lots of room for improvement, and more detail available on the atlas itself. I wanted to just highlight some of our focus populations and some of the opportunities we're hoping to leverage with further stakeholder relations with experts in these particular regions. So looking at pediatric palliative care, we look at a variety of elements within the focus populations, and including, is there a formal strategy for pediatric palliative care? Are there any pediatric hospice beds? What is the outpatient palliative care programming for this population? Is there any respite care available? Is there access to 24/7 specialist pediatric palliative care team within the region? And what are the specific education programs for increasing capacity to provide pediatric palliative care? You can see that in the Central East region, pediatric palliative care supports were largely lacking, and that's recognized as a gap for this region. There are two services of note which were highlighted in the context box. One I mentioned earlier, that Hospice Peterborough has ability to provide a palliative care bed and has a strategy with community partners, including a child and family life specialist that can provide support when needed. And the community care city of Kawartha Lakes is providing grief and bereavement service to palliative care, pediatric palliative care populations. So the color here is shown in white to just depict that it's really a lack of access to pediatric palliative care in this context. And I won't go through all of the other focus populations that Jose spoke to earlier, but certainly looking at various programs and initiatives and strategies happening across all of those types of elements within focus populations, including prisoners, immigrants, refugees, homeless, marginally housed, and LGBTQSIA+ populations. And we're really hoping to work with stakeholders from each of these focus populations to augment data and make sure we're capturing these indicators as robustly as possible. And I'll just end with a quick look at one of the elements for community engagement. So capturing the provision of palliative care by paramedic emergency medical services, looking at the integration of palliative care within EMS. You can see across the Central East zone that there's largely good integration of that, with the exception of one small region, but strategies are in place to change that, of course. All right, so I'm going to hand it back to you. That's a bit of a whirlwind tour, but I hope you can just see some of the amazing way we can capture data and really how meaningful it can be at the level to really inform care and policy. Thanks, Jeff.
All right, thanks, Leonie. Appreciate that. Just one last slide here. Some of you may be wondering what's next. We just go back to that slide, please. Thank you. So as you know, as you saw in the presentation, we have 3 provincial atlases that will likely be ready in the summer: Ontario, BC, and Alberta. So we'll likely hold another one of these sessions, maybe several sessions, to highlight the results from each of these atlases. And we've been working for some time now with our partners in each of those provinces to collect data and to begin reporting on it. The communication piece, of course, is critical on this. So not just communicating this broadly and widely to all stakeholders, but also communicating this to provincial, territorial governments and federal governments to help them become aware of where there's areas of excellence, where we're doing really well, and where there's opportunities for improvement. So that communication piece is absolutely critical. We don't want this thing developed to sit on a shelf. This has to be utilized, leveraged as a key tool to inform policy and funding decisions. But there's a lot of work in front of us still. So I mentioned earlier about the First Nations Inuit Métis Atlas. That is incredibly important. So that is on our radar, and with appropriate funding, we can get going on that in fairly short order. And of course, the balances of the provinces and the national atlas to tie everything together. So there's a lot of heavy lifting still to do, but the Central East sub-region as our pilot is done. I think there's a link in the chat that'll take you right there. So it's actually somewhat interactive as well. So I do encourage all of you to check it out and to go into some of this information in more detail. Leonie was able to give you a very high level as to what some of the different slides and domains represent, but I do encourage you to visit that. And on that note, we will wrap up the formal presentation and open it up to questions. And I'm just going to dip into the questions here to see what people have been asking. I'll start with the last one first. In the rural, okay, well, there we go. Where in Africa are you doing your research? Jose, do you want to talk about the African Atlas?
I'm providing some input on the African Atlas, but I'm involved as an advisor. It's the whole continent, so it's all the countries of the whole of Africa. And at the moment, the team has identified informants in almost all of them, about 85% of them, looking for some informants in about just 5 or 6 countries and waiting for response from the others. So, yeah.
Very good. Francis asks, in the rural area where I work, all primary care practices take care of patients through end of life at home and in the small rural hospitals and long-term care. We have access virtually to specialists when we need it. We do not have 24-hour home care and sometimes hardly any home care at all. How is this gap captured in the Atlas?
So I'll take a stab at it. Francis, very nice well, I can't see you, but very nice to bump into you again. So in the Atlas, we try and show and depict things graphically, as Leonie showed, but there are also, as you may have seen, some text boxes, because we understand there are nuances. So, for example, someone else asked as well for primary palliative care, that sometimes primary care clinicians will not refer when they should be referring to the palliative care team. So there's an opportunity during these focus groups for folks like yourselves to provide that input. And then we're going to capture that. And then those text boxes are where we start capturing some of those nuances. I hope that answers the question. Chris, I think you're going to say something.
Yeah, absolutely. So that was a fantastic question. And we're really trying to also get a little bit deeper down. So for example, in Ontario, we have the sub-regions as well as sub-sub-regions. So that helps us to depict a little bit of those differences and to make sure that this is actually graphically covered in the Atlas. So hopefully this opportunity to kind of like see where things are and giving everybody the opportunity to kind of like move forward from there.
Yeah, I think if I just will add, there's 3 levels of opportunity for input, which I know has been well described today, but we have the surveys. So, and then we also have interviews and then focus groups. And we really want to make sure that we capture all of these things like you were talking about, Francis. So making sure we've got it right and we're capturing the gaps in the way that even at a sub-regional level, things are working uniquely compared to a regional level. So we try as much as possible to have many levels of input to be as accurate as possible.
Great.
There was also an earlier question by Kelvin about the LGBTQ plus population, and I put a response. I don't know if everyone saw that, but we rely largely on the indicators that have been developed out of Navarra for all the different countries, including the African Atlas and the European Atlas, Latin American one. And obviously, this is work in progress. And every time they do an update, they identify more indicators. There weren't indicators for these populations that we wish to focus on. And so in the absence of specific indicators like vulnerably housed, LGBTQ plus, refugees, immigrants, etc., we thought we can't ignore those because we really want to shine a light on that. So we're using pretty open-ended questions to the informants and in the focus groups. And these questions include things like, how are you addressing the needs of these populations in your region? Are you aware of a program or approach or service that can be highlighted? Are you aware of gaps? Are there resources? Are resources being applied? And so at least we're putting it on the map, literally, so that hopefully by the next iteration, a few years' time, by then there will be more precise indicators, but at least get it going.
Andrea asks, it is my experience that some family docs feel they're able to support their patients and provide palliative care without needing to refer to a specialist team. Will they be captured in the Atlas?
Yoni, do you want to take that?
Yeah, sorry, I wasn't sure if you were jumping in. Yeah, so absolutely, one of the slides that I showed looks at the provision of primary palliative care by family physicians and the primary care clinics. And so absolutely looking at how that's happening at a regional level, and as well as their support from a specialist palliative care team if needed to address more complex issues. That could be virtual or in person, of course. So that's a very important indicator, because we know that a cornerstone of good palliative care is primary palliative care for people to provide it and to feel equipped and confident to provide it to their own patients. So absolutely. And there's one, if I may just jump in as well, there's one question above Andrea's question about the ideal number of hospice beds per 100,000 residents. And the Catalonia formula, which is captured in our data dictionary, speaks to 10 palliative care beds per 100,000, which is actually 8 of those are hospice beds and 2 are meant to be more acute palliative care units. And that's, of course, a big underestimate when you look at the context of an aging population living longer with multimorbidity, but that's at least an acceptable starting point that we still haven't achieved yet in Canada in many regions.
Susan asks about one of the gaps in end-of-life care for those with neurodiverse conditions, specifically across the age continuum. And of course, as we know, BC is in the process of doing their own mapping, and asks, has the palliative care for this demographic specifically been identified as a gap in your analysis in Ontario?
So we haven't, yeah, go ahead, Jose.
No, go on, Leon.
We have not been able to look at such specific types of populations. In keeping with the international atlases, we've been able to focus on those key populations, and so not that level of detail, unfortunately. I don't know if you want to add anything, Jose.
No, not yet. Although having said that, in another ECHO program, some of you may know that we are trying to begin to address that topic through a different ECHO community of practice. So I can invite you to that. Andrea asks another question about, will the precariously housed and homeless have their own atlases, other special groups? So actually the only group that will have their own special atlas is the Indigenous populations. The rest, including the vulnerably housed LGBTQ group, is within the atlas, the main atlas at this point in time.
We're definitely paying very much service also to community-based services. So we will be including things like compassionate communities and other services that are out there, including grief and bereavement support. So we're really trying to also paint the community picture in this one. And that is hopefully also addressing some of those issues that are brought up here, including care for vulnerable populations.
I think we've also answered Tracy's question based on what you were saying before. But I know, whereas I think my friend Peter had a question, and that was, is there anywhere in any of the international atlases that is evaluating the psychosocial spiritual care being provided and the education to support this perspective of the palliative and bereavement care.
So again, the answer to that is it's not going that deeply and that specifically into specific areas at this point in time. I am sure that the list of populations, the list of needs are growing, and that these will then be brought to the attention of the international team at the University of Navarra. But again, what's interesting is one's going to find a balance between too high level versus too in depth. You can imagine how challenging it could be to go into things like how is pain managed in a specific sub-region or region, how is psychosocial needs addressed in a region, sub-region, etc. But I suspect that as the process evolves over time, as the processes start getting more and more efficient and effective, and as a community starts evolving around these atlases, for example, people ask, how can they do the whole African atlas within a few months? Well, that's because they did it a few years ago and they've got the contacts and the people are acquainted with the methods. So now it's easy to go back to them and say, look, we would like to now focus on a specific population or a specific area of need. So I can see in the future things like that beginning to emerge.
Absolutely. And Francisco Borges also asked for rural populations and taking diversity there into account. One of the things that we're doing with the Atlas. So again, an invitation to look at what we have in the more interactive version that we have put it into the chat. That might be an opportunity for also see things like population density, services by population density, because we know that this is important aspects in this regard. Okay,
so that is a wrap. I've been informed by my colleagues to put a bow on this, and that's what I'm doing. So listen, thank you very much for all your thoughtful questions. A big thanks to our panelists as well for their time. I hope you're all very much excited with the potential that exists for these types of atlases. We're delighted to be working on them with our partners. More to come, as you can see. So look forward to presenting results from our other atlases that are upcoming. Please take some time to complete that survey so we can get the feedback from you to help us improve these sessions going forward. So thank you all. Appreciate your time today, and thank you for your interest, and have a great rest of your day. All the best.
Bye, everyone.